the PACU. So what is it? Well, by name, it is the Post-Anesthesia Care Unit. By function, it is the area where the patient goes immediately after surgery to recover. The PACU nurse will be doing a full assessment and a complete set of vitals and then reassessing as needed. Timing will vary by facility, but vitals should be taken at least every 15 minutes. That nurse will also be monitoring pain, nausea, intake, and output. If the patient had an inpatient procedure done, they will be discharged from the surgery unit and admitted to a med-surg unit, ICU, or a step-down after they have woken up from the anesthesia and their vitals have stabilized. If the patient has had an outpatient procedure, they might be discharged home directly from the PACU after they've woken up and have maintained stable vitals. In addition to the typical head-to-toe assessment, the PACU nurse has to observe the incision site or any surgical dressing for excess bleeding or drainage. So the question on this slide asks, what precautions would you expect to place a post-op patient on? Well, based on what we just talked about, we can place them on bleeding precautions. We also want to place them on fall precautions, since the effects of the anesthesia and pain medications may make them unstable on their feet, and also because we're worried about orthostatic hypotension. Always be very careful when you get a post-op patient up for the first time, and it's good practice to have them dangle their legs on the side of the bed first. And lastly, aspiration precautions are probably a good idea. We worry about an altered level of consciousness and the delayed return of a gag reflex. So if they're trying to take sips of water, we want to assess to make sure their gag reflex is present before, they're drinking, so we can make sure they can safely swallow. We also want aspiration precautions in place in case the patient begins vomiting from the anesthesia or the pain meds. So the next question is, why do you think these patients are typically prescribed IV fluids? Well, one, because we worry about fluid volume status and maintaining a blood pressure, and two, it helps to flush out the anesthesia, and three, it helps with constipation. So we know that we have certain things to pay close attention to if we are the PACU nurse assessing the patient or a floor nurse receiving the patient from the PACU nurse. And we need to know what is concerning and what needs to be reported. So let's start with vitals. We've talked about a potential drop in blood pressure, so we are monitoring for hypotension. Hopefully the physician has placed some parameters for you, but anything under 100 systolic is concerning. We also worry about bradycardia. Once again, hopefully you have parameters, but you should be concerned about anything less than 50. We also worry about a drop in respiratory rate. 14 or less should concern you. Then that brings us to monitoring oxygen saturation. Of course, this will depend on if your patient has a history of retaining CO2, but you want to look for deviations from their baseline. Patients often initially require some supplemental oxygen until they really start waking up from the anesthesia. And lastly, we have temperature. We've already touched on hypothermia, and it is common for patients to need warm blankets to get their temperature back to baseline. On the opposite end of the spectrum, we want to monitor for a fever because that can indicate infection or an adverse reaction to the anesthesia. Next on the list is bleeding. You want to monitor your surgical dressing for bleeding. If you notice drainage, it's good practice to grab a marker, trace the outline of the drainage, and write the time so you can monitor for any additional drainage and have a time reference. If your patient has a large abdominal or chest wall incision, we worry about dehiscence, and that is when pressure is placed on the incision site, causing it to open back up. So something you can teach your patient is to use a pillow as a splint when doing deep breathing exercises or coughing, and them hugging that pillow tight will help protect the incision from opening up. We've already touched on the bottom systems here, but make sure that you are monitoring the cardiac and respiratory system through vital signs and inspection and auscultation. For GI, we spoke about assessing for the return of the gag reflex and bowel sounds. You also want to assess nausea, vomiting, intake, and output, including constipation. For GU, you want to assess urine output and perform catheter care if an indwelling catheter is in place. Catheters are very common with urinary and reproductive system surgeries. With the anesthesia or from the catheter, bladder muscle tone can be affected and we can see urinary retention. So we want to make sure the patient is able to void and fully empty their bladder. And last on this slide is pain. And of course, we want to continuously monitor that and treat appropriately. On this slide, I have some things that patients will commonly report during the post-op period. So let's talk about why these happen. A sore throat is common due to airway placement during the surgery. The shoulder pain is common due to air trapping. So air gets into the body during surgery and gets trapped when the incision's closed up. So when that patient first sits up, since air floats, it'll float up and get stuck in their shoulder. The patient should get some relief from this when they lay back down, and that air will eventually all work its way out. This is the same reason that patients experience a lot of stomach cramping. So sometimes patients will want pain medication for this, but opioids actually slow down the gut more and make the problem worse. So a better choice for this patient would be something to relieve the gas. So something like a Gas X. And the full bladder could potentially be urinary retention, which we've talked about. So we want to make sure we're assessing that. There is an entire list of criteria that patients need to meet before they can be discharged. Their vitals must be stable. If they were requiring supplemental oxygen, they need to be weaned from that. Bleeding and drainage must be controlled. Your patient might have some drainage, and that is expected, but it should not be saturating their dressing. It should only be a small amount. They must be free from nausea and able to tolerate their normal diet. We'll typically start them with ice chips. If they do well with that, we'll advance to clear liquids, then full liquids, then to a solid, bland diet, and then finally to their normal diet. I always encourage patients to avoid really heavy or greasy meals. In my experience, it always seems like patients want fried chicken as their first regular meal, and it never turns out well. We also need to make sure that their pain is managed with PO medication. Remember, they won't be able to use IV pain medication at home, and we need to make sure that the PO medications are working to relieve their pain. I've even worked with some doctors who want the patient to be off of the IV pain meds for a full 12 to 24 hours before going home. And we've talked about this, but we want to measure their first void and make sure that they are not retaining any urine. And then lastly, we want to explain their discharge instructions and any follow-up care. So you may even need to schedule their follow-up appointment for them before they leave. And then once all of this criteria is met, your patient can be discharged.